So I'm just going to make a start because I don't want you to miss any more than a minute of our next presenter and our subsequent presentations. I know that you had less time with David for questions with David than you would have liked, and I don't want that to recur during the day. So it's my delight and privilege to introduce Dr. Melanie Harnett. She is a dear friend and an ex-colleague from the Behavioural Research and Therapy Clinic. She began developing the DBT for prolonged exposure protocol in 2005 and received a grant from NIMH in 2009 to formally develop and test the treatment in an open trial and a pilot randomized controlled trial. In 2015, she was awarded a second grant from NIMH to evaluate the effectiveness of the treatment in public mental health settings. Last year, she was awarded a third grant from NIMH to prepare to conduct a large-scale hybrid effectiveness implementation trial of DBT with the DBT protocol in routine practice settings. She's published extensively on topics related to DBT and DBT-PE and regularly provides training and consultation in these treatments, both here and internationally. She's licensed in the state of Washington, a certified DBT therapist and PE therapist and PE supervisor, and is board certified in cognitive and behavioral psychology by the American Board of Professional Psychology. It's my great pleasure to welcome Dr. Melanie Harnett.
Thank you so much for having me here. It's truly a pleasure. This is something Seth and Emily and I have talked about for years, and I'm glad it's all sort of come together finally to be able to be here this year. Emily and I just did a 4-day workshop on this treatment approach for the last 4 days here in New Haven. I know many people who attended are in the audience, so hello, it's been like 12 hours since I've seen you. And so it's great to sort of have this action-packed week of trauma and borderline personality disorder. So my disclosures just up front is that I am paid to do training and consultation in this treatment that I'm going to be talking with you about, and I also have federal grants to do research on this treatment. Before jumping in, I wanted to start with acknowledgments. So some of you, I'm sure, are already familiar more or less with this approach, and for some it might be new, but just to say, if ever there was sort of a daunting task to take on in life, sort of imagine yourself saying, Marsha Linehan, I want to take your treatment, and Edna Foa, I want to take your treatment, and I want to figure out how to put them together for super high-risk people. And these women are some of the giants of our field, so this truly has been an experience of standing on the shoulders of giants and sort of absolutely taking the amazing treatments and innovations that both of them have made and figuring out how to put them together, along with many other colleagues who have participated in these projects and treatment development with me. And I really, really want to thank the clients. So I've had many clients over the years who have participated both in the research studies with me and are my colleagues, but just in general. And this treatment wouldn't exist if not for the clients and their bravery, essentially, in being willing to go down this path with us. So as I'll talk about, nobody had quite tried to do this kind of treatment before with these very high-risk, severe clients, and these clients were in it with us, trying to help us figure it out. So the very first study that I did, it was sort of these 13 women. They all had borderline personality disorder. They all had PTSD. They were all suicidal, self-harming, all these things, and they came to call themselves very affectionately the guinea pigs. Because they knew that we were trying to figure out how to do this, and we couldn't have done it without all of the clients who have helped us along the way. So I may have bitten off more than I can chew in this talk. We'll see what happens, but I'm trying to hopefully get through a bit of sort of telling you why I thought there was a need to bring PTSD treatment into DBT, and talk a bit about the treatment development process and some of the challenges we ran into and how we addressed them, which was sort of how we ended up making adaptations, in particular to prolonged exposure in order to sort of make it fit in DBT and work for the clients that we were treating. Talk a bit about what this protocol actually is, and then review some of the research findings and sort of where we're at and sort of what we've learned about it. So to start with sort of why this treatment is needed. So I worked with Marcia Linehan. I started working with her as a postdoc in 2004, and I came actually from McLean, and I had been doing more sort of trauma work was sort of my background. And I had started to learn a little bit about DBT when I was an intern at McLean. And also a postdoc after that at Two Brattle Center, which used to be in Cambridge, Massachusetts. And I had started to learn about DBT, but I was really a trauma person in my heart, and I was really wanting to be able to treat PTSD and treat trauma among the kinds of people we were seeing in DBT. And the message I had been getting was sort of like, you can't do that. It's too high risk, it's too dangerous, they won't be able to do it, the treatments won't work. And so I decided to go to the source, which was Marcia Linehan. So I moved to Seattle and took a postdoc with Marcia and sort of came in the door saying like, okay, so you've said that we need to treat PTSD at some point during DBT, and like I'd really like to figure that out. And she said, that's great. If you can prove to me that there's a need that we actually should be doing that. So she's definitely a proponent of, if before you set down this path of developing some new treatment or some new protocol, that the very first step is you have to show that you actually need something new, that what exists already isn't enough. So let me tell you a little bit about sort of who it is that I was hoping to be able to reach with this treatment. So as an example, some of you might know, I worked for the last 14 years with Marcia at the University of Washington and just recently transitioned because Marcia is retiring over to the Seattle VA. So I am in like a whole new world. And I was thinking, I wonder, what veterans are going to be like as clients and how I'm going to do this with them. And so I'm just going to use an example of my very first veteran client, who I'm very excited about, but as sort of who it is we're trying to reach. So this woman came to me, so those of you who work in the VA system are familiar with it. She had a high-risk flag in her medical record, which means she's believed to be at very high risk for suicide. This thing pops up anytime anybody opens the medical record, and anybody who comes into contact with her is supposed to ask her about suicide risk. So she had recently tried to kill herself, a month before treatment. She'd taken a very big overdose and cut herself. A month before that, she had held a gun to her head, but her husband stopped her before acting. She cut herself regularly for non-suicidal self-harming reasons. She has a diagnosis of borderline personality disorder, all of the things that are very typical of going along with that, sort of the emotion dysregulation component, very intense emotions, and difficulty controlling them. She has a history of very severe childhood trauma. So she was sexually abused for years by her stepfather, who also was physically abusive at times, and generally lived in a family environment that she found to be very traumatic in terms of invalidation experiences as well, sort of communicating to her very intensely and repeatedly that she was wrong, that she was not good enough, that she was a burden to people, those kinds of messages in her home environment. So she'd had PTSD her whole life, essentially. She's in her 30s now. Came into treatment. She was also binging regularly and restricting food several days a week, smoking marijuana most days, dissociating for usually several hours per day, sort of very impulsive and irritable. And one of the things she did impulsively was join the military. Literally, it was just sort of decision one day in a bad mood, I'm going to go do that, and she signed up. So that's how she ended up in the military. So she came to me, and she'd done some DBT skills in a group, but our DBT full model program is new at the VA. That's partly why I'm there, was to set this up. And she walked in the door and she said, the biggest problem I have is my PTSD. Can we treat that? I really want to treat that. I've been telling people that I want to treat that for years, and I've never been able to get my PTSD treated. And that is my number one problem. And that is a very common experience for people with this kind of constellation of problems. All of these high-risk behaviors with just lots and lots and lots of different types of problems that are often, most or all of them, very severe. This woman isn't working. She hasn't been able to finish college. She's struggling to sort of function in her day-to-day life. And she's gotten a lot of treatment and hasn't been able to get her PTSD treated. We started last week with treating her PTSD. So that's who I was trying to reach. That's who this is for. The people who are sort of desperately needing their PTSD treated and have all these other problems that make it really difficult to get in there and do that, and where it's really hard to get treatment for it. So if we talk a little bit about how these things tend to go together, people who have PTSD, we know, are generally at higher risk of suicide, 6 to 7 times more likely to attempt suicide. Some estimates say about half or more might engage in non-suicidal self-injury at some point in their lives. PTSD is a disorder that has a very, very high rate of comorbidity, so 80 to 90% of people who have PTSD also have at least one other disorder. About 2/3 have 2 or more disorders, so there's a lot of comorbidity associated with PTSD. And if you put these particular set of problems together, the disorders that most often come along with that are borderline personality disorder or the mood disorders, major depression, for example. So if we're thinking specifically about people with borderline personality disorder, I want to make the point very clearly, not everybody with borderline personality disorder has PTSD. It's a very high rate, 30 to 50%, sort of depending on the study, but there's also, therefore, at least half of people with borderline personality disorder do not have PTSD. So as you're focusing on the people that do, when you have that combination of disorders, people with PTSD and borderline personality disorder tend to overall have more impairment. They tend to be more likely to be, suicide attempt more often, non-suicidal self-injury more often, worse depression, worse anxiety, more difficulty functioning, and a lot more sort of physical health, medical problems as well. So sort of a more complicated picture. And some of the reasons that might be true, so those of you familiar with DBT are familiar with chain analyses as sort of one of our methods of sort of trying to assess behaviors that we're trying to change and figure out what might be causing them and keeping them around, and what the different points of intervention might be to try to do something different. So this is an example of another client I treated who the behavior we were trying to change at this particular chain analysis was self-injury. Specifically, she had cut herself in the arm with a knife. And this is just an example of how PTSD and PTSD symptoms very often play a role in maintaining these high-risk, life-threatening behaviors that we are often trying to target in DBT. So this was a woman who had PTSD related to lots of childhood sexual and physical trauma, different client, but that's often the most common trauma type. And she decided sort of bravely to go to the July 4th fireworks celebration in Seattle, which is on a big park and a hill and lots of crowds overlooking Lake Union, where the fireworks go off from. And so for her and for many people with PTSD, being in a large crowd is intensely anxiety-provoking, being around just lots of people. But for her, it was not only that it was a large crowd, but that there were a lot of men in the crowd. It was particularly hard for her to be around men she didn't know, and a lot of people were drinking, using substances. So all of those things sort of made her incredibly vulnerable because they sort of brought on a lot of anxiety. And then sort of the yellow bar, the fireworks went off. And the fireworks going off immediately just cued fear for her, just loud sounds. Fear showed up, and she went quite quickly from fear into a flashback. And so all of a sudden she felt, was back in this incredibly abusive, sexually abusive experience. Felt like she was reliving it right now. Very commonly with flashbacks, people then become, that is sort of a form of dissociation, but become dissociated. She's kind of foggy, she didn't really remember. She left though, she just kind of took off and ran back to her house, which wasn't too far away. And doesn't really remember much about that. She was pretty dissociated. She got back to her house, she went to her room and immediately cut herself. And the cutting worked in the sense that it stopped the dissociation, like that. And then she sort of came out of it with the thought, like, now I'm safe. Her fear was reduced. And then longer term, she had some shame about having sort of run away from her friends and not said anything, some shame because she'd committed to me as her therapist that she was not going to self-harm, those kinds of things. But this kind of pattern, the point I'm mostly trying to make is that this is very, very common, that this is exactly sort of how we see things like flashbacks or nightmares or trauma memories or dissociation, which are all sort of trauma-related symptoms, showing up in a way where they're influencing people to eventually self-harm, try to kill themselves. They're sort of in the chain of events that are getting people there. And so this is very much sort of, these things go together and we have to figure out how to treat them as they are all influencing one another. So when I started down this path, again, trying to decide whether this was needed or not needed, sort of the existing standard of care, and in many places this is still the standard of care, is that if you have PTSD, sort of people will say simple PTSD, or PTSD without a lot of other severe problems going on around it, that you're sort of sent in one direction for treatments that are really just sort of PTSD-focused treatments. And if you have, if you're suicidal or you're self-harming or you have borderline personality disorder or other, severe problems, you're sort of sent in a different direction for treatment. So coming at this from sort of both of those directions was where I started was, well, so we have all these other evidence-based treatments for PTSD, so are those working already for this population of clients that I was trying to reach? So there are many evidence-based treatments for PTSD. These are treatments that their primary goal, sometimes their only goal, is to treat PTSD, and they're exceptionally good at doing that. So the ones listed here are the most common ones identified in clinical practice guidelines as being evidence-based for PTSD. This meta-analysis, just as an example, looking across lots of randomized controlled trials, found that on average in these treatments, of people who start the treatments, by the end, 56% of them no longer meet criteria for PTSD. And of the people who complete the whole treatments, it's more like 2/3 of them no longer have PTSD at the end, and that the majority of people, 80%, do complete these treatments. So these are some of the most effective treatments we have in psychology. Those are very, very big numbers and rates of remission for the field of psychology. So there's no doubt that these treatments work for PTSD for most people. The problem is they excluded the clients I was treating. For good reason. They're only trying to treat PTSD. That's all that they are intended to do. And so with that, this is a review of, again, this is 64 randomized controlled trials of these kinds of PTSD treatments, and what were the exclusion criteria that they used in those studies. So almost all of them exclude people who have psychosis or psychotic disorders. Almost all of them exclude people who have substance dependence problems. And suicidality is the third thing that is listed there, which includes usually belief that they're at acute risk of suicide, or they've had a recent suicide attempt, or they've had recent non-suicidal self-injury. All of those would exclude a person, and you can sort of see more of those. There is no PTSD treatment that includes people who are acutely suicidal or have a recent suicide attempt. The reason that number is not 100% exclusion for suicidality is because people don't list all their exclusion criteria, but also because the inclusion criteria for these treatments is very often that PTSD has to be their primary problem. And so PTSD has to be their most severe problem, and obviously suicide risk is higher than that. So that would keep people out of these treatments. I just want to make the point, though, that nobody excludes people anymore. There were a few studies that did a while ago. Nobody excludes people for having borderline personality disorder, per se. That's not an exclusion for these treatments. But it's all of these other behaviors and problems that very often go along with borderline personality disorder, like suicidality, substance dependence, those kinds of things that do get people excluded who have BPD. There are certainly some people with BPD who are perfectly appropriate for these treatments, though, also to highlight that point, who are not highly suicidal and don't have all of these other problems going on. There's some research showing that without all of these other problems, they can get through these treatments just fine and have the same kinds of outcomes as anyone else. So coming at it from the other side is, does DBT work? So the PTSD treatments were excluding the folks I was trying to reach. What about DBT, who was specifically trying to treat high-risk severe clients? So how is DBT doing in terms of its effects on PTSD? So those of you familiar with DBT will know that Marcia has this kind of stage model where in stage 1 of DBT, our primary target is getting out-of-control behaviors under control, these life-threatening behaviors, teaching people lots of skills in order to do that. And then when people have PTSD, we use a very much a here and now sort of present-focused approach, which is, if we think back a minute to that chain of the July 4th event and how that woman ended up self-injuring, our intervention in stage 1 for that is going to be to teach her a variety of skills to cope with, for example, being in crowds, to cope with flashbacks, to manage dissociation. We teach skills to sort of manage the fact that she has PTSD. But what we're not doing in stage 1 is going in and processing the details of the trauma that is causing her PTSD. So stage 1 is a little bit like disorder management. Like, we're teaching people to more effectively manage the fact that they have PTSD, but we're not actually treating the underlying disorder yet. So that is supposed to happen in stage 2. At the point at which people, achieve sufficient behavioral control, we move them into stage 2, and that's when the primary target becomes PTSD for the people who have that disorder. So back in her 93 manual, Marcia made 2 general recommendations about what you should be doing when you reach that point in order to treat PTSD. So one was to take the exposure procedures that are already in DBT, sort of part of our core problem-solving strategies, and sort of put them together in some more formal, structured way and use them to target PTSD, or take an established exposure-based treatment for PTSD and integrate it into the middle of DBT. So those were her recommendations back in 93. So theoretically, this is what everybody should have been doing since the manual came out. So one of the first things I did was look at Marcia's data when I first started working with her from her most recent randomized controlled trial to see, so how are we doing in DBT in terms of its effect on PTSD? So these were all women with borderline personality disorder, PTSD. They were recently suicidal and self-harming at baseline. And we see on the left there, the blue bar, that in 1 year of DBT, which is sort of the typical length for studies, in 1 year of DBT, only 13% of them reached remission of PTSD. 87% of the people who started the DBT with PTSD still had PTSD after a year of DBT. We added in a follow-up year where they weren't getting any more DBT. The rate went up a little bit. I'm not really sure why. But overall, when you look at PTSD treatments, what we would expect, if you remember a few slides ago, is that 56% of anybody who starts the treatment is going to remit from PTSD by the end. So 13% in DBT, 56% in active PTSD treatments. And so I thought, okay, there's room for improvement here. We can try to get ourselves closer to what PTSD treatments are finding. And so then I tried to figure out, like, what's getting in the way? Like, why aren't we getting better results for PTSD during DBT? So my first hypothesis was, well, maybe in general, DBT just isn't effectively treating Axis 1 or co-occurring disorders. So I looked across all of these disorders, and the good news is that DBT is actually kind of shockingly effective at treating some of these disorders. So all the way on the far left is substance dependence disorders. 87% of people remit from substance dependence disorders who get DBT. 68% remit from major depression. 64% remit from eating disorders. We are really good at treating those disorders. The ones that are sort of to the right are all of the anxiety disorders. Things kind of fall off a bit. And then PTSD is the disorder that is least likely of any of them to get to remission during DBT. So the answer did not appear to be just sort of generally we were not targeting co-occurring disorders. We were not targeting anxiety disorders, and particularly PTSD. So the question was, well, maybe it's because, I thought, well, maybe it's because the people who have PTSD are just more severe. They're sort of more, behaviorally discontrolled. It's just going to take longer to get them to a place where it would be potentially appropriate to treat their PTSD. And maybe 1 year of DBT just isn't long enough to get them there. So this is that sort of same sample of women with borderline personality disorder, PTSD, who are suicidal, self-harming. What I did in this study was apply the criteria from prolonged exposure therapy, sort of what they say they exclude people for, and sort of applied those to this sample of women to see would they have been eligible to do prolonged exposure therapy in theory at any point during the year of DBT if we use those criteria. So that blue bar is sort of the most clear-cut criteria from PE. Is that they can't be at imminent risk of suicide and they can't have recently attempted suicide or self-harmed. So you see at pre-treatment, nobody was eligible, and that's because the study explicitly recruited for people who were actively self-harming and suicidal. But over the course of 1 year, by the end of the year, we see 68% of them would have been eligible using those criteria, and that means for the last 4 months of the treatment. If we made it a little bit harder and we said, well, they also can't have severe dissociation, they also can't be substance dependent anymore, by the end, 50% would have met those criteria for the last 4 months of treatment. So the answer didn't seem to be that we weren't getting people with PTSD stabilized, that DBT just wasn't working well enough to help them get to a place where PTSD treatment would have been effective. So my final hypothesis was, well, maybe the clients don't want the treatment. Maybe the therapists are offering it and they're saying, nope, I don't want it, I'm not doing that, go away. And so the one on the left, the pie chart, are women who participated in research with me, all had borderline personality disorder and PTSD, and were suicidal, self-harming. And they came in for their intake assessment into this treatment study and were given a one-page piece of paper that described what DBT was, described what PE is, and described what a combined treatment would look like, and were asked, which treatment would you prefer to receive? They could only pick one. And just from reading a piece of paper about these treatments, 76% of them said they wanted both treatments. The rest only wanted DBT alone. Then in my more recent research I've been doing in public mental health agencies in Philadelphia, I did some focus groups there, and I met with clients who were actively engaged in these DBT programs, consumers in these settings, and I sat with them for an hour and I described this treatment approach to them, and they got to ask me questions and all this kind of stuff, and at the end of our focus group, same question, what treatment would you prefer? They were already all in DBT, and 90% of them said they wanted both. So the problem does not appear to be that the clients don't want the treatment. So here's what I've come to with sort of lots of talking to people and everything, sort of what I think was interfering, has interfered, continues to interfere in lots of places, is for a long time there was no clear way to decide when somebody was ready. Like, what is that point between stage 1 and stage 2, and when can we move on to treat their PTSD? As well as in the DBT manual, there was no clear protocol or structure or method for how to actually treat their PTSD whenever they got to that sort of magic point. And then there's a lot of fear around doing this treatment, both from the therapist's perspective and from the client's perspective. Often the therapist more than the clients. Of sort of doing trauma-focused treatment with high-risk people. It's understandably anxiety-provoking for everyone involved. So with all of these things going on, PTSD just simply wasn't being targeted in DBT. And what happens if we don't treat it during DBT? So what happens is people don't do as well. So the people who entered treatment with PTSD where it wasn't treated tend to have worse outcomes in DBT. So in particular, there's a less improvement in suicidal and self-injurious behaviors. People with PTSD, there's a lower likelihood of getting them to a place where they're no longer at acute risk of suicide. And they tend to continue to have more severe BPD symptoms at the end of treatment, which to me quite clearly argues that we have got to treat their PTSD to boost their outcomes. So, so the new standard of care that I'm trying to promote is truly having a comprehensive and integrated treatment where we are treating every problem that our clients have, including PTSD, in one treatment that is DBT based. So I'm going to talk about the treatment approach that I have been developing. So this is a little bit of a story, maybe a saga, I'm not sure, of sort of going down this path, having what we thought was a reasonable idea, but not really knowing what we were doing entirely, and trying to figure this out along the way. So the very first problem we had to solve was we needed to decide on what PTSD treatment we were going to use. So remember that Marcia's recommendations were to either use the exposure procedures that were part of DBT and kind of put them together somehow and treat PTSD, or just take an existing treatment and put it in the middle of DBT. I decided to go the route of taking an existing treatment. There was no compelling reason I could come up with to reinvent the wheel when we have all these existing treatments. So the one that I picked was prolonged exposure therapy. So the reason for picking PE, prolonged exposure, was largely because exposure therapy in general has by far the most research support behind it of any, sort of the most studies behind it of any treatment for PTSD. Marcia, in the recommendation she did make for what we were supposed to be doing in stage 2, is very clear that we should be doing exposure, so sort of an exposure-based treatment rather than perhaps a more cognitive therapy approach. And that's just more consistent with DBT in general, where we tend to be more behavioral than cognitive in our orientation. And I always just want to put out the caveat there that yes, like we picked prolonged exposure, we had a reason why, and it's possible that some of these other evidence-based PTSD treatments could work if they were put in the middle of DBT in the same way, sort of using these same principles. There just isn't research on that yet. Nobody's done that, and nobody's used those other evidence-based PTSD treatments with high-risk clients with borderline personality disorder, so we just don't know at this point. So we picked PE. So what is PE? How many of you are familiar with prolonged exposure therapy? Some of you? Okay. So unlike DBT, prolonged exposure is a reasonably straightforward, brief, clear treatment. And so it's a protocol where it's session by session, and very clearly sort of going into your sessions what it is you're going to be doing in that session and what you'll be doing in the session after that, and it's all kind of mapped out in a very sort of structured, manualized way. So it generally lasts between 10 to 15 sessions is typically how long it takes. The first 2 sessions are sort of getting ready for treatment. There's a lot of assessment and orienting and psychoeducation about PTSD, sort of building your hierarchy for doing in vivo exposure, just sort of doing the things we have to do to get ready to do the active treatment. And then sort of the active treatment really begins in session 3. And there's 2 main treatment components of prolonged exposure therapy. So as we heard in the first talk this morning, what we know from research is that avoidance is one of the sort of core thing that maintains PTSD over time. And people who have PTSD tend to avoid in 2 different general types of ways. One is that they tend to avoid things in the world, so people, places, things, smells, sounds, all that kind of stuff that remind them of their trauma or that they perceive as being dangerous in some way. And so they're doing all this avoidance out there in the world. And then the other type of avoidance is avoidance, cognitive avoidance of their own thoughts, their own memories of their trauma and what they've experienced. They try to push those out of their head as quickly as they can and not talk about their trauma, not think about their trauma in any kind of detail or feel the emotions about it, right? So with those kinds of avoidance going on, that's kind of what keeps PTSD going over time. It's of course totally understandable why people avoid. It works very well in the short term to reduce anxiety or shame or whatever emotion comes up, but in the long run it actually keeps those things going. So prolonged exposure therapy has 2 main treatment components, each targeted at one of those types of avoidance. So in vivo exposure, what some of you might be familiar with, is sort of real life exposure. So this is kind of if you're afraid to be in crowds, then we would be having you do in vivo exposure in a gradual way, sort of working yourself up to being in a crowd and learning that when you're in crowds, you don't get attacked, bad things don't happen. You're able to survive those situations. So that's just an example of sort of in vivo exposure out in the world. The other type of exposure is called imaginal exposure, and this is what we're doing in the therapy sessions with clients, is exposure to their trauma memories. So thinking about and talking about their trauma memories in detail, sort of describing out loud to us in the sessions specific traumatic events that we help them pick which ones we're going to target, and telling us the story of that trauma over and over and over in as much detail as we can get it, so that they can experience the emotions that come up related to that and start to get a new perspective on these events and what happened to them and what they mean about them, what they mean about the world, and really sort of changing some of these beliefs like it was my fault or I'm a bad person because of this, or nobody in the world can be trusted because of this, and really getting some of those things to shift by talking about what happened and kind of looking at it together with what's called processing, sort of processing their beliefs and emotions about it after the imaginal exposure. So those are the 2 main treatment components, just so people have some sense of what we're doing in prolonged exposure. And then the standard prolonged exposure Edna Foa's treatment has one final session at the end of all that, sort of the termination, saying goodbye and reviewing progress. So we took that treatment and we're going to put it in the middle of DBT, was the goal. In general, my goal was to not change it as much as possible, to stick as closely as I could to the evidence-based treatment and only make changes if something clearly was not working in some way for our clients. So now we'll hear about all the things that didn't work, where we made some changes. So the first thing is that, for the clients we were treating in DBT, their suicide risk and other sort of higher priority problems they had made it so that going straight away to try to treat their PTSD just was not wise. We agree with everybody else in the world that you should not be treating PTSD with somebody who's at acute risk of suicide or actively at high risk in some way. And also, our clients tended not to be able to tolerate distress well. So, I just described exposure to you, so you can all imagine the distress that comes up if you sit and describe a super traumatic event that happened to you over and over, right? Like, it's intended to elicit distress. And if our clients weren't able to tolerate that, and we're going to do things intentionally or unintentionally, but just sort of this is how they've learned to cope, to shut off the emotions, to avoid, to not talk about it, to push it out of their heads as quickly as they could, the treatment wouldn't work. There's just no way exposure will work if you don't have some capacity to experience emotion without avoiding. So with those problems in place, it sort of was impossible to start PTSD treatment right away with our clients. So we're using, Marcia's stage-based treatment model. So they're coming into treatment in stage 1, which we talked about, sort of severe behavioral discontrol. We start with standard DBT. We're doing stage 1 DBT. And then at the point, which I will define in a minute, of sort of when we believe they've now achieved sufficient stability and behavioral control to move on, we add in this DBT prolonged exposure protocol, and they're doing it at the same time that they continue to get all of standard DBT. So they're still attending skills group, they're still having some individual DBT therapy, they're still doing phone coaching, and our therapists still go to consultation teams. So the 4 modes of standard DBT are still going on, and we've just added in a second treatment as part of their individual therapy sessions. And then after that, hopefully we've got some time left in our treatment and we sort of go back and are doing standard DBT, at that point addressing whatever problems are still there for a person, which are very often about sort of how to truly sort of build that life worth living now, that PTSD is no longer such a big problem, and sort of building new relationships, getting jobs, going to school, sort of doing all these things in the world that they didn't used to be able to do because of all of the trauma-related suffering. So that's sort of the general model. We also, as they're starting treatment and they're in stage 1 of DBT, and we're hoping to be able to get them to stage 2 so we can treat their PTSD, the solution was also to try to figure out how to get them through stage 1 as quickly as possible, so that we could get to the PTSD treatment, which in our view for most clients is sort of their core problem, and we want to be able to get there. So we use some of the strategies that are in DBT for building commitment and contingency management, sort of figuring out how to reinforce them effectively for making changes, but so that they will both want to treat their PTSD, which most of them do anyway, coming in, but also in particular getting them more motivated to stop all of these life-threatening behaviors, the self-harm, the suicidal behavior, more rapidly, in order to be able to treat their PTSD. So for my veteran client, who I just started with probably 9 weeks ago or something, she came in saying, I really want to treat my PTSD, like I've been wanting to do this forever and nobody will do it with me. And so I said, that's great. I would love to do that with you. Frankly, I'm kind of good at it. And I really want to do that with you. I totally agree with you. We need to do that. And then in the next breath said, but I won't do it with you, as long as you're still self-harming, as long as you're still trying to kill yourself. You have got to stop those behaviors first, and I'm going to help you do that. And as soon as you do, then yeah, we can treat your PTSD. And that is incredibly motivating for the average client. Because they know that their PTSD and their trauma is sort of at the core of their misery and is driving a lot of the reasons that they want to be dead, and a lot of the reasons they are self-harming, and a lot of other problems in their lives and their relationships and everything. So that client, this is not atypical. When I told her she had to stop these behaviors if she wanted to treat her PTSD, she stopped. So she hasn't self-harmed since I told her that, and it's been 8 weeks, which is why we started PTSD treatment last week. And so that contingency can be incredibly helpful, and sort of giving people a reason to work even harder to be able to get something they want. Like, shockingly, exposure therapy for PTSD is a reinforcer, right? It's like the carrot we're holding out. Do they actually want to do exposure therapy for PTSD? No. Right? Like that's, but they want to not have PTSD anymore. And when you tell them there are treatments that work, you do not have to suffer for the rest of your life with this particular problem. It is treatable. We can treat it. It will make a huge difference in your life if we do, but you've got to stop these other things first. Super motivating. They want the relief. They don't want to do exposure necessarily, but they're willing to do it if it will get them the relief. So then what are the criteria that we use for deciding when somebody is ready, when they can move on to the PTSD treatment? We developed a bunch of criteria and tried lots of them in different times in different ways. When we were back developing the treatment, I can tell you where we landed and sort of what we've been using for quite a while now. So those of you familiar with DBT, there's a target hierarchy of sort of what we go after in what order, with the life-threatening behaviors being our #1 priority. So similarly, these readiness criteria are set up to kind of match the target hierarchy from DBT. So the #1 thing is they can no longer be at imminent risk of suicide if we are going to treat their PTSD. So this is things like they can't be, rehearsing killing themselves. They can't be sort of actively making plans to kill themselves, saying they're going to kill themselves in next week, or acquiring the means to kill themselves. Things like that, sort of clinical indicators we're usually looking for. So intent and planning, means acquisition, all that kind of stuff. Not committed to staying alive. Those kinds of things are likely to put somebody in a category where we still believe they're at imminent risk. Just to say very clearly, we do not expect people to no longer have urges to kill themselves or no longer have suicidal ideation. That's not imminent risk. Everybody we do this treatment with still has suicidal ideation and urges to kill themselves. We just want to have evidence that they are not going to act on them, and there's no reason to think they have intent to go out and kill themselves soon. So not at imminent risk. So the most clear-cut rule that we came up with that we use, because we wanted clients to have a clear amount of time that they could work towards, was that for 2 months they have to be totally abstinent from all forms of suicidal behavior and all forms of non-suicidal self-injury, no matter how high or low risk those behaviors are. They can't be self-harming at all for 8 weeks, which is why I'm in week 9 of treatment with this client and we're starting. Because I told her the first time I met her, you need to stop these behaviors for at least 8 weeks before I'll do this with you. So she did. So 8 weeks is our rule, and that's there mostly for contingency management reasons. In order for people to change their behavior, you have to be very clear what the expectation is so they know what needs to be different. So 8 weeks free of those behaviors to start. Then we also want to see that they're able to control urges to engage in those behaviors. So most people, that's very clear. In order to get 8 weeks free from them, they're showing us they're using skills, they're managing urges. But sometimes there's people who manage to pull off that 8 weeks of no behavior by avoiding everything in the world that makes them want to kill themselves or self-harm. And for those folks, we want some evidence that they can come into contact with the things that typically make them want to self-harm, make them want to kill themselves, and that they've now got skills and they're using them and they're able to manage those urges effectively before we will move on. The next category in our target hierarchy in DBT is therapy interfering behavior. And so for us to not be willing to move into PTSD treatment yet, it's got to be very serious behavior that is essentially making it to a level where we think there's no way prolonged exposure therapy is going to work. Because they're not participating enough in treatment to either get a big enough dose of the treatment, so people who hardly ever show up for therapy, for example, or who come 40 minutes late for your 60-minute session, things like that, where they're just not going to get enough treatment for it to work. Or they're having difficulty participating effectively in therapy sessions. Something is making it hard for them to collaborate and engage. People who dissociate for 80% of your session, or who are coming to sessions drunk or high most of the time, or come to the sessions and refuse to do anything that you're asking them to do. Things like that, where essentially you're not going to get any treatment into them in a way that will be likely to work. We have to get those problems aced out first. There's sort of no point in trying to put them through such a hard treatment if we don't think that they're going to be able to do it yet. So we will address really serious therapy interfering behaviors first. And now we're in sort of DBT's quality of life domain as the third tier, and at that point clients get to decide what they want to do. So sort of therapists get to kind of decide when there's high-risk things going on or therapy interfering things going on. But once those are sort of addressed, it's really totally up to clients what their goals are and what they would like to do. So this is there to say, the client has to want to do it, and they have to have decided that PTSD is now their biggest priority and what they want to target next. And then the last thing is often the hardest thing, which is we want to see now that they have learned skills and sort of developed a capacity to experience emotion, so that they can actually sit with an emotion in the context of exposure and not immediately distract, avoid, push it away, start thinking about killing themselves to get away from it, but that they can sort of have an emotion more or less and experience it we're usually asking for about 30 minutes, because that's how long exposure tasks are. And so that skill in particular is one that we're sort of mindfulness of current emotion, that we're actively really working on building during stage 1 to make sure that they'll be able to do exposure and be emotionally engaged enough that it has a shot at working. So those are our criteria. And as you can tell, most of them are subjective, except for our 2-month rule. So a lot of this is sort of clinical decision making done between the client and the therapist and the larger consultation team. So once a person meets those criteria and technically they're ready to go, our next problem was our therapists were afraid to go a lot of the time. So the clients were ready, but the therapists were still delaying and not wanting to do it. And so that's where in DBT we have our therapist consultation team, which is really helpful for whatever problems therapists might be having that are interfering with treatment, because therapists do therapy interfering behavior as well, for sure. And so we use our consultation team to address whatever those therapist factors might be. They're often things like they're afraid the client's going to get worse, or they're just not confident in their ability to treat PTSD, or they're worried about hearing about the details of trauma and how that might affect them, things like that. So sort of whatever the sort of therapist factors are, we try to address those in our consultation team so that they won't interfere with the client being able to get the treatment. So then we are in the treatment. We're starting session 1. One of the things we do in session 1 is a trauma interview to pick out which trauma the person's going to work on in treatment for their imaginal exposure. Prolonged exposure therapy is designed, this sort of standard PE, to treat one trauma. So the trauma interview is just designed to assess one event, which is more typical for the clients who are in those treatments, and not at all typical for the clients we were treating, who typically have multiple types of trauma, multiple perpetrators of trauma, childhood trauma plus adult trauma, some single event traumas like accidents or a rape, as well as lots of chronic repeated trauma like childhood sexual abuse that went on for 10 years. So our clients were sort of swimming in a sea of trauma, and it wasn't sufficient to think we just needed to treat one of those things. And I'll talk in a minute about what I mean by non-criterion A traumas. So we modified this to say on average we're going to expect to treat at least 3 traumas in this treatment, and sort of modified that initial trauma interview to identify 3 target traumas. This is just a random example rather than just one, because of the multiple traumas. We also added in this concept that Seth mentioned earlier of traumatic invalidation. So if you look at the DSM and the definition of trauma that's in there for the diagnosis of PTSD, that's the criterion A. It requires that there be physical injury, threat to life, threat to physical integrity in some way. And our clients, many of them have had those kinds of experiences, and they've also had other kinds of experiences where there was no direct physical injury or threat to their lives, but that were very, very traumatic to them. And so this is from Marcia's skills manual. She defined it in there. But things that we might also conceive of as being more like sort of verbal abuse, or emotional abuse, psychological abuse, those kinds of things, bullying by peers, for example, or sort of organizational invalidation. I'm working with like transgender veterans, talk about organizational invalidation in the military. Those kinds of experiences, we'll hear more about that this afternoon from Monica Williams also, but considering that sort of invalidation of themselves as a person, there's something wrong with you, you're bad, you're evil, you're unlovable, those kinds of messages being incredibly potentially traumatic as well. So we will treat those as well. In standard PE, they teach one skill. They teach breathing retraining. DBT has an arsenal of skills. And so we brought in a much broader range of potential coping skills. So in the early stages, in the first session of PE, we build out with a DBT skills plan for what are the skills that people are going to be able to use from DBT to manage urges that might come up or difficulties with exposure. We pull from any skill that we have in DBT to help them plan to cope ahead and get through exposure safely and effectively. The next problem was there's sort of a psychoeducational component to prolonged exposure early in treatment, where they're educating people about PTSD and the diagnostic criteria for PTSD. And those are certainly relevant to our clients, but they tended to have a lot of other problems, sort of common trauma reactions that weren't typically included in just sort of a straight PTSD description or diagnosis. So we made this sort of common reactions to trauma and put it into a dialectical framework. So those of you sort of familiar with DBT, you're used to seeing these arrows and axes where there's sort of two extremes, where there's truth and validity on both ends of these, and we're trying to get people somewhat into the middle, into more balanced ways of living. So we sort of did this for trauma reactions. So I don't have a lot of time to go into detail, but sort of emotion being one of them, where flooding is at the top, and this is sort of the PTSD flashbacks, nightmares, intrusive symptoms, emotional reactivity being really high, and then sort of bouncing to the other end of total numbness, being detached, numb, dissociation, not having any emotion, and kind of going back and forth between those two. Relationships, we'll see different patterns in our clients. There's sort of the one end, the sort of desperate connection, where they're terrified of being alone. They're sort of overly trusting, sharing information, personal information, like more quickly than might be wise. Sort of staying in situations where they're really being harmed because it's better than having to be alone. Kinds of situations, or the other end of the people who think the only way to be safe is to be alone. And so they're detached from everybody, don't get emotionally, physically close to anybody, sort of the other extreme of this sort of really detached independence. And then we have the behavioral, the red one, which is at the top, sort of what we think of often in borderline personality disorder, this sort of reckless disinhibition, all of those behaviors, substance use, self-harm, suicide, all of that kind of stuff going on up there. Or the other end of this pole is this sort of very rigid control over your behavior. In order to feel safe, I have to have everything perfectly planned and prepared. I can't be spontaneous. I have to know what's coming, I have to follow a clear schedule, I have to do things in certain order, that kind of stuff at that end. And we see all of these often in the same person. And so we're trying to orient our clients to a little bit of a different framework than just PTSD by itself for thinking about their reactions. Exposure therapy historically, traditionally was designed to target fear. PTSD used to be considered an anxiety disorder. It's not anymore. It's actually a separate trauma-related disorder, but exposure is generally used for problematic fear and anxiety. And so as we went into this, certainly our clients have lots of anxiety and fear, but shame was often even more prominent than fear for our clients with lots of trauma in their history. And so one of the adaptations we made, because we wanted to make sure we were really doing a sufficient job of targeting their shame as well, it was in the in vivo exposure part of the treatment, that real world exposure, going out and doing things in the world that you want to avoid. We also explicitly are targeting things in the world that cause them to have shame. And in DBT, we use the term unjustified shame, shame that doesn't fit the facts of the situation. If you do whatever the thing is, you're not actually going to be rejected, for example. So there's a lot of different ways you can do sort of shame exposures. Things like, different things will elicit shame for different people, but crying in front of people, sharing information about your trauma with people will definitely do it. Sometimes saying no to things, asking for what you want, acting as if you deserve to take up space in the world in some way will bring up shame for our clients, or anything that's around being imperfect. Making small mistakes, sending an email with a typo in it, or being late for things, or any of those kinds of things will bring up shame for a lot of our clients. Being competent can bring up shame. Accepting compliments, accepting praise, talking about something that they're good at, for example, and then lots and lots of shame about their bodies. Related to looking at themselves in mirrors or sort of wearing certain kinds of clothes or not, all sorts of things related to their bodies will bring up shame. So just to say, we target these things with our exposure as well, because shame is such a problem for our clients. Another issue was that PE didn't include methods in it to sort of make sure we're monitoring potential suicide risk and other things that could occur during the treatment. So we are nothing if not intrepid self-monitoring people in DBT with our diary cards and other things. But so they're doing their diary card still, so we're getting things like urges on that and behaviors on that. But we also have a form that we use before and after every exposure task they're doing where they rate urges to kill themselves, urges to self-harm, things like that, so that as they're doing exposure, we're tracking if there's anything going on that we need to worry about from a risk perspective. Another issue was that our clients struggled often during exposure to stay emotionally engaged at sort of effective levels that would be needed for exposure. And if you think about this sort of broadly speaking on kind of a bell curve, there's a pretty wide range in the middle where you can have emotions and be effectively engaged and exposure will work just fine. And sometimes we run into snags if they get too intense, this over-engaged end of the emotion, or too under-engaged, just sort of numb and flat and not able to access emotions. So when we were running into problems with emotional engagement, our solution was to use DBT skills. So again, we have lots and lots of skills we can use, but we might coach our clients to use skills that will reduce emotion or use skills that will increase emotion, depending on what the particular problem is. The last thing I'm going to say super quick before just showing you some data in my last minutes here is this other part of the treatment. After you do imaginal exposure in your sessions, you do what's called processing, which is sort of talking through with them what their thoughts are about their trauma, their emotions are, seeing sort of processing their reactions to this. All I'm going to say at this point is that part of our sessions, it's DBT. We are doing DBT. This is a model of everything that exists in DBT for therapist strategies. We just go back to being DBT therapists in that part of our exposure sessions to process the trauma and try to shift some of those trauma-related beliefs and emotions that are keeping them stuck. So DBT is just used for processing there. And just to make the point, too, that our clients had lots of other problems. The PTSD was not their only problem, which is why we also keep DBT going the whole time. So that we have other parts or another session where we're just doing DBT, but where we can use DBTs kind of wrapped around this whole thing so that they can address whatever other problems come up in DBT, ideally while still continuing with the PE and not having to stop. But we have this other treatment going on to address whatever else might show up, so we don't have to stop to address other sort of chaos. I'm going to skip over that. So research findings quickly before I wrap up, just to give you a super high overview of sort of where we're at. So I've done a couple of studies originally at the University of Washington, sort of the treatment development open trial, then a randomized controlled trial. And most of this data are from those two studies so far. The first question was, can we get people through this in a year of treatment? Is it possible to think we can do all of this in 1 year? And so across these two studies, which was the initial open trial and then this randomized controlled trial, on average 60% of the clients started the DBT PE at some point during their year of DBT. So 60% of them initiated it. On average, they were getting to start the DBT PE after 20 weeks of DBT. So stage 1 of DBT was taking 20 weeks, which is a lot faster than we thought it would be. Again, that's an average. Like my veteran starting after 9 weeks with a high risk flag in her chart. And when people don't start if they didn't get to the point of starting DBT-PE in the year, the main reason people didn't get there was because they dropped out of DBT. So they dropped out of DBT before it would have been reasonable to start. Of the people who started, 73% of them completed it, so the same rate as you get in standard PE and all of that. And on average, it takes us 13 sessions. So we're right in the same ballpark as standard PE, treating people with, on average, way more traumas, getting through, on average, between 2 and 3 traumas in that period of time. So 13 sessions total. It's not a long treatment for most people. So yes, for most people, we're able to get them started and through it in our year of DBT. The next question, of course, was it safe to do this with high-risk folks who had been recently self-harming and suicidal and often still having urges to engage in those behaviors? So, you know, I mentioned a minute ago that before and after they do every exposure task, we have this form where we ask them to rate their urges, immediately before, immediately after. So this is the data from about 700 different exposure tasks that our clients in our research completed. And what you see is that most often, 80% or so of the time, there is no change whatsoever in their urges. So if they start in marginal exposure in your session at a 2 out of 5 on urges to kill themselves, they will finish imaginal exposure and still be at a 2 out of 5 on urges to kill themselves. So most often, the exposure itself has no immediate impact on their urges. The next thing that is sort of most likely to happen is that their urges actually come down. You know, so they come into session sort of full of anxiety about doing this exposure, for example. Urges might be a little higher because of that. They do the exposure and they get a little relief and urges come down a little bit. And then the least likely thing of all to happen was that urges would actually go up immediately after doing exposure. It can happen, but about 8% of the time. And that's, you know, not always, it's not certainly a terrible event all of the time, but it's just not the most common thing to happen at all. And we've got DBT there to help us if we need it, if urges get high. Which is great, but what we really care about is behavior in DBT. So this is from the randomized controlled trial, where the 2 conditions were DBT alone or DBT with the extra DBT-PE protocol. And this is the rate of attempting suicide at all, at least once during the year of treatment, or engaging in non-suicidal self-injury even once during the year of treatment. So we see at the green bar is people who got DBT alone, and the yellow is people who got both treatments. That if you look at these numbers, that, you know, among the people who completed these treatments, people who got DBT-PE were actually 2.4 times less likely to attempt suicide and 1.5 times less likely to self-injure than people who got DBT alone. So my sort of thing I generally say about this at this point is sort of it seems like it's actually less risky to treat their PTSD than to not treat their PTSD. And obviously when it's well-timed and all that kind of stuff, but if you don't treat it, these behaviors are going to stick around. Is it effective for PTSD? So this is looking across those first 2 trials, the open trial and the randomized controlled trial, just highlighting the yellow bars are the people who completed the DBT-PE, and this is the rate of remission from PTSD. The ones that are circled, the 80% is in the randomized controlled trial. 80% of the people who completed DBT-PE no longer had PTSD at the end, compared to the green is the people who got DBT alone, 40% of people in DBT. So the message here is that you can double the rate of remission of PTSD by adding in this protocol to DBT. And it also improves lots of other things. So these are sort of different secondary outcomes. The yellow bars are the people who received the DBT-PE. Green are people who got DBT alone. This is the rate of recovery, which is defined as essentially getting people to the level of normative functioning on these different domains. Shame. 100% of people who got DBT-PE had normative levels of shame at the end. 20% of people who got DBT did. So you sort of see this pattern across all these different outcomes that kind of adding in and treating their trauma kind of turbo boosts DBT. and the effects that we get across a range of outcomes. Just to say quickly, and I'm going to stop for questions, we're moving this out of the lab, the research clinic at the University of Washington into community practice settings. I've got data from clients treated by clinicians who go through the workshops that I do, 241 clients that they've treated, and showing that their PTSD outcomes look very comparable to what we got in our academic research clinic. There's a published trial with veterans, which has very good outcomes, and then there's some pilot data on adolescents coming out of McLean 3 East also having good outcomes. I just finished my study in public mental health agencies in Philadelphia 3 weeks ago, so I don't have the data to tell you too much about it, but knowing that we're also evaluating it now, we've evaluated it in these settings that are primarily racial ethnic minorities, 100% Medicaid populations, and getting similar patterns of results. So very exciting to see it also working in routine practice settings. And I will leave that up there for you to read. Those are sort of some of the quotes from clinicians who participated in the study of getting the workshop training and then telling us what kinds of outcomes they were getting when they went out and tried it with their clients. So thank you, and I'll, oh God, I had one more. Take-home messages. There you go.
Melanie, thank you so much. I have, it feels like almost half an inch of index cards of questions to ask you. I'm going to dive into one that's come up a couple times in different ways. Many PTSD treatments assume survivors are in a place where they are, quote, safe, even if they don't perceive this to be true. And helping them accept this is a key part of the treatment. What happens when clients are not actually in a place of safety? For example, for transgender, sexual minority, or racial ethnic minority individuals who face discrimination daily with real threats to physical well-being. How can we help these individuals? And of course that also applies to maybe young people who are either at home or at school or in workplace, also experiencing traumatic invalidation.
Yeah, great question. So the one sort of clear-cut, guideline is that we're not going to be starting to do a PTSD treatment with somebody who is still actively in physical danger. So somebody who is, in an intimate partner violence kind of relationship where it's ongoing abuse in some way, that is not the time to be treating their PTSD related to that trauma. The focus needs to be on getting them physically safe. Now, for these other types of trauma where there's still ongoing traumatic things happening, maybe on a day-to-day basis, just because of your identity as transgender or racial ethnic minority, sort of experiencing discrimination that is traumatic and invalidating throughout your day, or adolescents who might still be in a home environment where the invalidation that we think about in DBT is still active. There's no sort of clear-cut rule on this. It's sort of an issue of what is the higher priority. Is there something about the environment that we can be changing, or is there some way that we can be helping them to cope more effectively with the reality of their environment in some way, or is it time to move in and treat their PTSD? We actually, definitely have had success with treating PTSD. For people who are still experiencing those types of more invalidation kinds of trauma, when those are ongoing. And what that can do is to help people be able to sort of get a new perspective in some way on these experiences, where they don't get so overwhelmingly distressed by them when they happen, but sort of most importantly, where they don't view these experiences as meaning that they're bad, that there's something wrong with them, that it's their fault, where we can sort of help them sort of get a new way of interpreting these things when they're happening to them that don't cause quite so much suffering, while holding up the change side and trying to get those things to stop happening at the same time, as much as we can control that.
One other stack of questions speaks to or asks about what do you do if you think that someone is actually hurting themselves while they're taking part in prolonged exposure treatment, or if they actually do hurt themselves?
Yeah. So we have sort of the same principle of we won't start the treatment if they're actively self-harming. If they, in the middle of the treatment, self-harm again, we will also stop the treatment. But we will stop it, ideally briefly. The danger with that is that we don't want to potentially reinforce the self-harming behavior, for example, like if you self-harm, you don't have to do this really hard thing anymore. But sort of we have that rule where we will stop for at least one session where we had intended to do DBT-PE, where we won't do it and we'll do standard DBT instead and our regular sort of chain analysis, solution generation, figure out what went wrong, and all that kind of stuff before we'll pick it back up again. And sometimes that might take a while. Sometimes it might be one session. It sort of depends. But mostly we have that rule, that contingency in place that there will be a stop because that keeps people from doing the behavior in the first place. So very often, we'll see these chains of like, I'm doing PE and I had this day of really high urges to kill myself, and we do a little chain to see how they manage those urges, and the thought showed up, well, if I hurt myself, then I'm going to have to stop PE, and I won't get my PTSD treated, and I don't want that, so I'm not going to do it. So that's largely why we have that rule in there too.
And what if you're worried that your client is doing it, or you're thinking that this is kind of set up for them to be very motivated to underreport? Yeah,
so that's a common concern, is that perhaps our clients will lie to us. Perhaps like say they've stopped self-harming so they can start treating their PTSD when they haven't actually stopped, or they don't tell us if they're doing it one way or another. And so that can possibly happen. We haven't had that experience. There's only been a handful of cases for us where that's happened. And I think we sort of handle that how we generally handle concerns about dishonesty and DBT, with just being very straightforward and asking questions, and by any chance, could this be going on? Or, and sort of telling them the reasons why not being honest with us will likely make the treatment less effective for them if we don't know what's going on. So.
Thank you. Does complex post-traumatic stress differ in its treatment than standard DSM-5 PTSD in populations with comorbid BPD?
So that could be its own talk, right? Like and there's lots of sort of different camps that have different thoughts about all of these potential diagnoses. So complex PTSD versus PTSD versus borderline personality disorder, for example. And so complex PTSD is now in the ICD. Is it 11? Is it 11? Yeah, but it's not in the DSM, where there's still only PTSD. And borderline personality disorder, some people have certainly made the argument that it can be conceived of as sort of a trauma-related disorder for many people. So there's certainly a lot of overlap. And I mean, I'm not trying to totally avoid the conflict, but genuinely as a clinician, like I kind of don't care. Like I'm treating the problems that they have, whatever diagnoses we want to put them under or not. But yes, very often the people that we have in this treatment would probably meet criteria for the complex PTSD diagnosis and ICD as well, yeah.
Okay, one more. As a consumer with BPD and untreated PTSD, what options do I have to receive treatment?
Good question. So I have a website, dbtpe.org, that on it has a provider directory of people who have gone through my intensive training. In DBT-PE, you can search by state, by country. There's a lot of people in there these days. So if you're looking for somebody trained to do this, hopefully you can find somebody in your area there. And there's also other PTSD treatments, sort of depending on what you need. I also just sort of want to make the point that not everybody needs this. I sort of think of the combined DBT with this extra DBT-PE as like the jackhammer of all PTSD treatments. Like this is kind of the most intensive, biggest treatment that we've got. And there's a lot of people who can get their PTSD very effectively treated with short-term, standalone PTSD treatments. And by all means, start there if those seem appropriate for you, and get here only when needed.
So just to get clear, Melanie, if people are no longer engaging in life-threatening behaviour, that would be your recommendation, that people get their high-risk behaviour under control.
Yep.
But once they've got that, they're abstinent for a certain period of time, they would be able to take part in other evidence-based treatments for PTSD.
Yeah, you could just do standard prolonged exposure therapy or cognitive processing therapy or EMDR, those kinds of treatments.
The ones that you identified in your slide on meta-analyses as evidence-based treatments for
Exactly.
PTSD. Okay.
Yep.
Thank you so much.
Sure.